The webcast will begin in 2 minutes. The webcast will begin in 1 minute. Welcome to the Leukemia and Lymphoma Society of Canada's webcast, New Frontiers and Emerging Treatments for Acute Myeloid Leukemia. In this webcast, Dr. Brandwein will discuss research innovation and emerging treatments for acute myeloid leukemia and the risk factors for this disease. My name is Sonia Muto. I'm the Community Program Coordinator for the Leukemia and Lymphoma Society of Canada. I will be the host of this online event. During the webcast, you will hear only my voice and the speaker's voice. The presentation will last approximately 40 minutes and will be followed by a 15-minute question and answer period. This presentation is also being recorded. Therefore, you will be able to listen to it again on our website while following along with the PowerPoint presentation. We will send you an email when the recording is available. Next slide, please. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We offer guidance and support every step of the way. We know the current situation presents many challenges to those affected by blood cancer and their families. The community services managers can help. They are compassionate connectors that can help those affected by a blood cancer cope with anxiety and isolation during these times. Please do not hesitate to contact a community services manager in your area. We offer a variety of educational resources and support services to those affected by a blood cancer. On our website, you can access free information booklets, fact sheets, educational videos, and webcasts about specific blood cancers, treatments, and practical information. Our peer support program is a support service that matches people affected by blood cancer, caregivers, and their families with trained volunteers who have been touched firsthand by a blood cancer and share similar experiences. It can be a useful program these days to counter the effects of isolation. Subscribe and listen to our podcast series, The Blood Cancer Experience, to learn more about treatment and research and to hear stories from people affected by a blood cancer. Available on Spotify, Apple Podcasts, and anywhere you enjoy listening to your podcasts. From November 16th to the 20th, we will launch our very first virtual leukemia conference. Join us from the comfort of your home to learn from experts about leukemia research innovation and attend breakout sessions on AML, ALL, CLL, and CML. It is my pleasure to introduce our speaker today, Dr. Joseph Brandwein. Dr. Brandwein is a clinical hematologist, director of the Division of Hematology, and professor of medicine at the University of Alberta. He obtained his MD from McGill University, followed by internal medicine residency at Dalhousie University, hematology residency at Vancouver General Hospital, and a leukemia autologous BMT fellowship at the Toronto General Hospital. He worked for over 13 years in the leukemia program at Princess Margaret Cancer Centre in Toronto and has been involved in clinical and translational research in acute leukemia for many years, with over 150 publications. Thank you for joining us today, Dr. Brandwein.
Thank you for giving me the opportunity to speak with you all today. I know that most of you are very familiar with acute myeloid leukemia. Many of you have gone through treatments for this, and many others of you know people close to you who've gone through this treatment. What I'd like to do today is primarily to talk about, as the title indicates, new frontiers. So I'd like to give you some examples of how research into the biology of AML has been translated into new diagnostic and treatment approaches. And I'd also like to explore how this new knowledge is expected to change the field of AML therapy in the coming years. So most of you know, AML is a blood cancer arising from bone marrow stem cells. These primitive cells are unable to differentiate or turn into normal blood cells. And this is because there is a block in this differentiation of cells. So they're stuck at a very primitive blast stage. They grow, proliferate, multiply, and gradually take over the bone marrow and spill into the blood. Since the bone marrow is the blood factory, this results in the bone marrow being unable to make normal blood cells, leading to severe anemia, causing profound fatigue, low platelet counts, leading to bleeding, and low white cells, leading to infections. And we know if untreated, this is a rapidly progressive and fatal disease. The standard treatment we give for AML is to give what we call remission induction chemotherapy, usually in hospital as inpatients, to achieve a complete remission. This is then followed by consolidation chemotherapy, and in many cases, followed by an allogeneic stem cell transplant, where the patient receives more intensive treatment, followed by infusion of donor stem cells. As many of you know, AML treatment has a number of limitations, the first of which is toxicity. Chemotherapy does not generally recognize what the good and the bad cells are, and it kills them equally well. And particularly rapidly dividing cells are very susceptible to these drugs, leading to bone marrow suppression, effects on the gastrointestinal tract, etc. This results in many side effects, some of which can be severe and even life-threatening. Because of this toxicity, the treatment is limited generally to younger, more fit patients. Second problem is limited efficacy. Remission rates are in the 60 to 80% range, but overall cure rates are much lower. So why does treatment fail in some cases, or in many cases? First is the toxicity itself is a limiting factor. Second, some patients fail to achieve remission because their disease is resistant to our treatments, while others will relapse later because some of the cells have survived even the intensive treatments that we give. In older patients, this situation is even more challenging. The average age of AML is about 70 years, and most older patients are unable to tolerate the intensive chemotherapy and transplants due to the toxicities. And for those patients, the main treatment options include low-dose palliative chemotherapy, including hypomethylating agents, particularly azacitidine, which is what we have in Canada, and low-dose cytarabine. While these treatments are much better tolerated with less side effects, they're also much less effective, with remission rates only in the 20% range and effectively no cures. The average survival with this treatment is in the range of 8 to 12 months. The only alternative really in terms of standard treatment is supportive care alone with transfusions and antibiotics. And again, really has generally a poor outcome. So this is basically showing you the spectrum of treatments according to age groups. For almost all younger patients receive intensive chemotherapy with intent to cure the disease, whereas most older patients tend to receive the more non-intensive treatments. And in this in-between age range, what we do really depends a bit on the patient, their medical status, the disease status, etc. And overall, the patients who walk through the door of most institutions, a little over half will get the intensive treatment, maybe a third will get non-intensive treatment, and the rest will end up receiving supportive care. So this slide shows you a bit about the timeline in terms of how AML therapies have developed. So the standard chemotherapy that we have given for AML was developed in the late 1970s and early 80s, so it's basically 40 years old. Allogeneic stem cell transplants were developed in the 80s and refined into the 90s. And for several decades, we really had no advancements at all in the treatment of AML. We were still using the same treatments. However, behind the scenes, there was a great deal of research being done into our understanding of the biology of AML. And this led to some very important advances. First of all, the development of important diagnostics, which I'll talk about in a moment. But more recently, the proliferation of new treatments, most of which have just becoming available in the last 2 or 3 years. So this treatment of AML is really starting to undergo a real revolution right now. So what I'd like to do is focus a little bit on some of these new developments and how they arisen, and maybe look at several of these as examples of these new treatments. So if we want to improve treatments of AML, how do we do this? Well, in order to do this, we really need a very good understanding of the underlying disease biology. What I mean by that is what makes these cells behave abnormally, what makes them stop becoming normal blood cells and not differentiating, and what makes them multiply so rapidly, and also what makes them resistant to our treatments. So what have we learned so far with all of this research in the last 15, 20 years? Well, one of the most important things we've learned is that AML is not a single disease. It's actually many diseases. And it arises from mutations in genes and chromosome abnormalities in bone marrow cells. And these are usually acquired mutations. These are not things that people are born with. They usually acquire them later in life, usually by chance. Sometimes they occur as a result of prior chemotherapy or radiation, and sometimes they can transform from an underlying bone marrow disorder, such as a myelodysplastic syndrome. And it turns out there are many different gene mutations that can give rise to AML. This graph gives you an idea of the spectrum of molecular abnormalities that have been identified in AML. And this shows you what we call the spectrum of driver mutations. That means mutations that drive the development of AML. So these are all important in how AML arises. And if you do mutational profiling in AML samples from patients, you find that almost every case has at least one of these driver mutations. And in fact, most of them have 2 or more of these mutations. So you have patients that will have 2 mutations occurring in the same cells, sometimes 3 or more. And so our thinking about AML right now is that it often arises as a stepwise process. And we call that process clonal evolution. So at some point in life, by chance, a person will develop a mutation in a single cell in the bone marrow. And that mutation may not cause any changes at all in the blood. But at some point down the road, there may be a second mutation that arises that may result in the bone marrow not working effectively. Sometimes that will cause the development of a myelodysplastic syndrome. And then you may get yet another mutation occurring, which will result in the outgrowth of these very primitive blood cells, which become blasts. And this is the development of AML. So when you have a diagnosis of AML and you analyze these, you may have several different mutations, but they didn't all arise at once. This was a stepwise process that may have evolved over years. So what's the significance of detecting these mutations? Well, one of the important things we've learned in the past 5 or 10 years is that these different mutations have very different prognoses. Some of them are considered good mutations, and what I mean by good is they're still a bad disease, but I mean that when we give our standard chemotherapy, there's a much higher likelihood of being cured. Even without a bone marrow transplant or stem cell transplant, they're much more curable. On the other hand, there are others that are considered bad mutations, which means that they're less curable and have a much higher risk of relapsing with treatments. And these are the patients that we tend to send for stem cell transplantation and try to reduce the risk of recurrence. There are many other mutations that don't have any apparent impact on prognosis, but we can detect them. So this just gives you an idea of some of these different types of mutations that fall into a more favorable or good category, and some of the mutations that fall into a less favorable or adverse prognosis, we call it, category, and correspondingly cytogenetic or chromosome abnormalities, which also fall into a good or bad risk category. So this has been a very important recognition, and we use that information, as I said, to determine which patients to send for allogeneic stem cell transplants. But a more recent development as a result of detecting these mutations is that we're starting to target some of these mutations therapeutically. So people have learned the mechanisms of how some of these mutations lead to AML, and that has led to the design of drugs which specifically target the mutations and block their effects. So I'm going to show you 2 or 3 examples of some of these areas and just demonstrate how the research has been translated into treatments. The first one, I think the one that's been best developed, is the FLT3 mutation. This is one of the most common mutations occurring in about 30% of patients with AML. So FLT3 is a protein that sits on the surface of the leukemia cells. This is the cell membrane or the surface of the cell. And what this does normally is it gives it signals or sends signals to the cell to cause them to multiply and grow. And when this FLT3 is mutated, it can actually drive the pathways to become more active. The most common mutation is called an ITD, or internal tendon duplication mutation, actually causes this to go into overdrive. So it's if you're driving a car down the highway and the gas pedal gets stuck to the floor and can't be released, and the car is going faster and faster out of control. These cells are proliferating very rapidly. These patients present with rapidly rising blast counts in their blood. And we know that when we treat these patients with our regular chemotherapy, the relapse rate tends to be relatively high. This knowledge of the structure and mechanism of FLT3 and what it does when it's mutated has led to the development of selective FLT3 inhibitor drugs, so drugs that actually block the effects of FLT3. There were 2 different generations of drugs. The first are drugs that we already had on the shelf and just by chance recognized that they were able to block the effects of FLT3. And then there was more recently a second generation of drugs that were developed, which are more designed specifically to very potently block that pathway. And so this led to what has now been considered a landmark study for patients with FLT3 mutated AML. This is called the RATIFY study. This was an international collaborative study in many countries, including Canada, around the world. Patients with newly diagnosed AML were tested rapidly to see if they had this FLT3 mutation. The mutation was present. Everybody then received standard induction chemotherapy, but they were randomly assigned to receive either this FLT3 inhibitor drug, midostaurin, which is a pill, or a placebo. They then went on to get more treatment, either with midostaurin or placebo, along with chemotherapy, It's a double-blinded study, so we didn't know who was getting what. At the end of this study, we looked at the results, and as you can see on this graph, there was a difference. The blue curve, which is the group that received midostaurin, had a better survival than the group that received the placebo. This difference doesn't look large, it's about 10%, but this translates into potentially hundreds of lives saved worldwide. This was a real landmark study because it was the first time that we were able to demonstrate that one of these targeted inhibitor drugs actually was of benefit and improved survival. And this has now become part of our standard treatment for patients with FLT3 mutated AML. I mentioned that there are other FLT3 inhibitor drugs that have been looked at and studied. One of the newer ones that was, again, designed to very potently block this pathway is called Gilitinib. This drug by itself can produce remissions in patients with relapsed AML about 40 to 50% of the time. And another study was performed and came out about a year ago. And this was looking at patients with FLT3 mutated AML that had actually relapsed following regular chemotherapy. It was, again, a randomized study. Patients were assigned to two groups, either to receive standard intensive reinduction chemotherapy or Gilitinib, which was just a pill taken once a day. And when they looked at the outcomes, it was found that the group that received Gilitinib had a higher chance of going into remission and on average lived longer than the group that received even intensive chemotherapy. And they did that with a lot less side effects. So another study showing that a targeted inhibitor drug, even by itself, can be a benefit. Unfortunately, most of these patients ultimately relapsed, but it did show that it actually worked. And it's now been approved by Health Canada and is becoming available to patients with relapse disease. So FLT3 inhibitors, you can see, are already changing the landscape of how we treat AML in a number of respects. As I mentioned, because patients with this ITD mutation have a higher relapse rate, we usually tend to transplant them in first remission to try to reduce the risk of relapse. But even after a transplant, the relapse rate is still in the range of 40%, which is unacceptably high. So the question people have then asked is, can we use these FLT3 inhibitors to prevent them from relapsing after an allogeneic stem cell transplant? And there have actually been two studies now that have looked at this question, and they were both designed in a very similar way. One was a German study and another study from China. And what they did was they took patients who underwent a stem cell transplant with FLT3 mutated AML, and they randomly assigned them to receive either a FLT3 inhibitor, in this case sorafenib, or matching placebo. And again, double-blinded study, so patients or physicians didn't know what they were getting, and they followed these patients along. These studies actually just came out this month, so it's hot off the press. This is the German data, but the Chinese study was very similar, had very similar outcomes. And what these studies found was that the group that received the FLT3 inhibitor had better survival and a better outcome. The left side curve here is what we call relapse-free survival, which means being alive and not relapsing. This curve on the right is the overall survival of everyone. And as you can see, the group that received sorafenib, the blue curve here, did better than the group that received the placebo. And this, again, was very important now, I think, because it's showing for the first time that we have a treatment that can reduce the risk of relapse following a stem cell transplant. So again, this field is moving very rapidly, and we're finding better ways of using these FLT3 inhibitors as time goes on. And there are many other studies that are ongoing testing these various FLT3 inhibitors in different settings in AML. Are there any other mutations that have been targeted in a similar manner? Well, the answer is yes. Unfortunately, most of them we haven't got to the stage of targeting them, but there are several others where we're starting to see some very promising effects by targeted agents. I'm just going to show you another example now. This is a completely different mutation called IDH. It stands for isocitrate dehydrogenase. This is an enzyme in the cell that helps the cells produce energy. Some of you may remember this Krebs cycle if you did biochemistry in school. This enzyme turns out is mutated in about 15 to 20% of patients with AML. Not as common as the FLT3 mutations, but not rare either. And over the past 5 years or so, people have looked at this and asked the question of what is going wrong with these cells, and they've managed to work out the mechanism of what goes wrong. And it turns out this mutated IDH enzyme produces an abnormal substance in the cell called 2-HG, stands for 2-hydroxyglutarate, which then moves into the nucleus of the cell and blocks the effects of certain important proteins in the nucleus that normally will cause these cells to differentiate and become normal white blood cells, red blood cells, and platelets. So they actually found the mechanism how this mutation was causing this block in differentiation that is the hallmark of AML. And this led to the development of designer drugs that were selectively targeting the mutated IDH. So these are pills, again, that only act on the mutated IDH protein. It doesn't affect normal protein, normal cells. And when they use this, they were able to show that it blocks the production of this abnormal 2-HG, removes the block in the differentiation. And when they use these pills to treat patients with IDH mutated AML, about 30% of patients, about a third, actually went into remission. And these researchers were able to show very convincingly that unlike regular chemotherapy, which actually kills the cells, these pills were not actually killing the cells. It was causing them to differentiate. So basically turning bad cells into good cells. They were becoming normal white blood cells that eventually would die out as they normally do. And those patients that went into remission, shown in the red curve, actually ended up doing better and lived longer than the patients that did not respond. Fortunately, by itself, it wasn't a cure, but again showed that using a targeted agent like this against a mutated protein can actually be a benefit, at least to some patients. And this pill, because it's so selective, has very few side effects. It doesn't affect normal cells in the body. So I'm showing you a couple of examples of how understanding of what makes these cells behave abnormally has led to very promising treatments. There's another question, though, which is what makes leukemia cells resistant to our chemotherapy treatments? Why aren't they all killed? Why did they relapse? Well, what people have learned is that the process of cell death is very important. This is not, when we give patients chemotherapy, it's not that these cells just explode randomly. The process of cell death is actually a systematic process, and it goes through a series of reactions within the cell, eventually resulting in the cell dying. And this is called programmed cell death or apoptosis. And this is what happens when you give patients a chemotherapy drug. It activates this programmed cell death pathway. And there are certain critical proteins that are involved in this process. However, there are other proteins in the cell that block or inhibit this process. And one of those key ones is called BCL2, which is present in the cells, and it actually is overexpressed in AML cells. And when it's overexpressed, it prevents this programmed cell death pathway from working properly and prevents the cells from dying when they're exposed to chemotherapy. So this knowledge and understanding and a knowledge of the structure of BCL2 has led for a number of years to the development of the drug venetoclax, which is a potent, highly specific inhibitor of this BCL2 protein. Again, it's a pill by itself, very well tolerated, relatively few side effects. If you give this pill alone to patients with AML, some patients will go into remission, a relatively small percentage. But more significantly, when you add it to chemotherapy, it actually markedly enhances the ability of the chemotherapy drug to kill the cell. We presume because it's preventing the action of the BCL2 and allowing the cell to undergo through this programmed cell death pathway. So this process is called synergy, and that the effect of two drugs together is greater than the sum of the individual effects. So this led to a number of studies. The landmark study, which is, again, hot off the press, it just was published last month, was a randomized clinical trial focusing on older patients with AML, the ones that we would normally give azacitidine to. So this was patients over the age of 75, or some patients a bit younger if they were not otherwise eligible for intensive chemotherapy. So these patients enrolled in the study were randomly assigned to receive either azacitidine plus this venetoclax pill, or azacitidine plus a matching placebo. And again, it was double-blinded. We didn't know who was getting which. And they looked at the results. They found that the patients that received the combination with venetoclax had a much higher chance of going into remission than the group that received azacitidine alone. When they then followed these patients along, and this is a survival curve from that study, the group that received the combination of azacitidine plus venetoclax on average lived about 5 months longer than the group that received azacitidine alone. But on top of that, there's a subgroup out here, maybe a third of patients that are out beyond 2 years, remaining on treatment and still going. And so this, again, has become a landmark study by itself, in that they were able to show clearly that adding this BCL2 inhibitor actually improved responses and outcomes in these patients. This is very new. Azacitidine has not yet been approved, venetoclax has not yet been approved in Canada for the treatment of AML, but it is being widely used in many parts of the world, and starting to use it, and it's highly likely that it is going to be approved and will become the new standard of care for patients who are not eligible for intensive induction chemotherapy. And this is, again, it's another example of a new type of targeted treatment that has arisen from our understanding and knowledge gained from all of the research which has been done looking at the biology of AML. So I've shown you a few examples. There are other drugs that are in development or have just recently been approved. Time doesn't permit a full discussion of these different ones, but I think there are more that are coming. And now that we have a lot of these new treatments, the question is, where do we go from here? I think we're really just at the beginning. Now that we are discovering these drugs that are actually effective, we need to find better ways to use these drugs. Second thing we need to do is we need yet more drugs. We have a long way to go before we can cure most patients with AML, and we need to find new agents that target some of the other mutations and pathways in the cell. This is just the beginning. The third thing, which I'll talk about a little bit in a moment, is can we harness the immune system to fight leukemia? So with respect to the first point, I think it's really apparent to those of us who've been involved in these studies that there is no magic bullet for AML. It's not as if we'll be able to give someone one pill and it will cure AML. AML, unfortunately, is a very tricky disease. I mentioned how heterogeneous it is, but it also tends to find a way around your treatments. And no matter what you give, it sooner or later becomes resistant. And so a single pill is unlikely to cure AML. And I think if we want to have a chance of curing more patients with AML, we're going to first have to move some of these new drugs into frontline treatment, where they're likely to be less resistant, but also use them in combination with other agents, so that if we attack the disease from several different directions, that hopefully will prevent the emergence of resistant subclones that cause relapse. And there are many clinical trials that are either underway or being designed right now, which are looking at different combinations. And they're maybe combining these new targeted agents with standard chemotherapy drugs, or they may be actually targeted agents being used together in combination. And I think over the next 5 years, there's going to be a lot of these trials done, 2-agent, 3-agent, and maybe even 4-agent combinations to try to find what the most effective regimens are with the least toxicity. And it's very important that we do these studies. What about finding new drugs? Well, fortunately, there are many other agents that are in development and are under study right now. There are many pathways that have been discovered as having an important role in the growth of AML cells, helping these cells to resist treatments, and selective targeted agents have been developed that are blocking many of these pathways, and some of these, or many of these, are in clinical trials. There really isn't enough time to go through these in exhaustive detail, but I did want to show you one example of one of the innovative new drugs that is just getting into clinical trials. And this is called APR-246. So when I showed you earlier the spectrum of mutations in AML, I talked about some of the bad mutations. I talked about FLT3. One of the other ones is called TP53. This is a mutation that is involving this apoptosis pathway, and it's way up here. It's an important protein that helps these cells undergo programmed cell death when they're exposed to chemotherapy drugs. And it turns out that this gene is mutated in some patients with AML, and particularly those that have AML that's arisen from prior chemotherapy or from prior myelodysplastic syndromes. About a third of them will have TP53 mutations. And unfortunately, when it's mutated, it doesn't work anymore. So these cells don't go through this programmed cell death pathway properly. And it makes these cells very resistant to the chemotherapy drugs. So when we give chemotherapy or standard chemotherapy to people with these mutations, the remission rates are very low and relapse rates, unfortunately, are very high. And even stem cell transplants often don't work. So it's been a real frustrating group of diseases to treat. But all of the research that's been done behind the scenes, not just discovering what this P53 does, but looking at the chemical structure of this protein and how does it change when it gets mutated, has led to the development of a designer drug, which is called APR-246. And what this drug does, it actually inserts into the structure of the mutated protein and basically reactivates it and makes it function normally again. So this, again, is totally different than what we have done with regular chemotherapy. So if something breaks down in the engine of your car, what we've done normally is we basically blow up the car or smash it up and get a new one. But what they're doing here is they're actually bringing out a toolkit and repairing the abnormality and making it work again. So very innovative. And when they've used this this medication, this mutated protein actually disappears, and you can then detect normal functioning protein again. So by itself doesn't do that much, but when you add it to chemotherapy, it makes the chemotherapy more effective. So there have been some clinical trials combining this agent with azacitidine, and the remission rates, again, are much higher than you'd get with azacitidine alone. This is in a very early stage of clinical trials, but something that we're very interested in and very promising. So just one example of some of the many agents that are in very early stages of clinical trials, and hopefully we'll be participating, and we will be participating in Canada in many of these studies, looking at some of these new agents. And it's very important that we try to enroll patients in these trials so that we learn which ones work and in which patients are potentially benefiting from them. What about harnessing the immune system to fight leukemia? This is something that we've dreamt about doing for many years. Can we do this? Well, in fact, in a sense, we're already doing this. That's one of the main principles behind an allogeneic stem cell transplant. We're actually using the donor's immune system to fight the leukemia, recognizing it as being foreign and then killing it off. And that's one of the important mechanisms by which it helps to reduce the risk of relapse. Unfortunately, for those of you who've undergone a transplant, you know that there are side effects. And one of the biggest problems is this graft versus host disease, where the donor's immune system actually recognizes the patient's normal tissues as being foreign and can make people sick. So it would be really nice if we could find a way to harness the person's own immune system to help it fight the leukemia. There are some very promising treatments that are being developed right now. One of these is called BITE antibodies. So BITE antibodies stands for bispecific tumor engaging antibodies. And what this is basically a a combination of two antibodies that are fused together or joined. They bind to the surface of the tumor cell, and they induce the body's own immune cell, the T cell, to come in, recognize this tumor cell, and attack it and kill it. So it's a directed killing by the patient's own immune system. And this is now being used as a standard treatment in acute lymphoblastic leukemia, and the drug is called blinatumomab. But there are similar BiTE antibodies that are currently in clinical trials treating AML. So targeting different proteins on the surface of AML blast cells to see whether it can be done as effectively. And some of the early results are looking promising. Anti-tumor vaccines, that's also been something we've really wanted to have for many years. It would be great if you could inject somebody with a protein, the way we do when we vaccinate people against influenza, and induce the immune system to attack the leukemia. There has been research done in over a period of a few years trying to investigate this, looking at specific targets, one of which is WT1. It's been a bit disappointing to this point, but those studies are still ongoing. What about CAR T cell therapy? You may have heard about that. It's been all over the news. This is a new type of treatment that's just come out in the last few years. And what we do with this type of treatment is we actually remove the patient's own immune cells, T cells, from their body by a process called apheresis. We treat the T cells outside of the body by inserting genes to make them recognize the tumor cells as being foreign, grow them outside the body, reinfuse them, and these activated T cells will then seek out and kill the cancer cells. This has already been shown to be very effective for certain other blood cancers, such as acute lymphoblastic leukemia and some lymphomas. There are some early clinical trials in AML. It's been, unfortunately, a more challenging disease to treat with this modality. One of the problems is that the protein targets on the leukemia cells are usually also present on normal bone marrow cells as well. So if you use this, there is a high probability that you will basically destroy the person's own bone marrow along with the disease. So in this setting, to this point, it really needs to be used in the setting of a stem cell transplant. In other words, use this treatment, then follow it up by rescuing the patient with infusion of donor stem cells. And there have been a couple of studies out of China that have now shown that it is possible with this CAR T cell therapy to eradicate leukemia, which is resistant to regular chemotherapy, and then transplant the patient and rescue them. So it's very early days, but it is looking promising, but there's going to be a lot more work done in the coming years using this treatment modality. So if I can take out my crystal ball moment at the end and just speculate on what I think AML treatment is going to look like in the next 5 to 10 years. I think what is happening now is we're moving into a phase of what people like to call personalized medicine or precision medicine. So instead of what we've done in the past, which is to treat everybody the same way with the same treatments, we're going to be looking at the patient's individual disease characteristics and tailoring the treatments according to that. So we'll need to have rapid mutational profiling so that we can identify the spectrum of mutations within 2 or 3 days. We can get this now, but it usually takes 2 or 3 weeks, but we will have that. Technology is going to make it much more rapid. And once we have those results, we'll be able to pull targeted therapy combinations off the shelves to treat patients effectively and hopefully with a lot less toxicity than in the past to achieve remissions. Some of them might be curative, but if there is a risk of relapse, we would then look at harnessing the immune system to get rid of the remaining disease. I think that it's likely that allogeneic stem cell transplants will still be with us for quite some time because it is still the most effective way we know of to reduce the risk of relapse for many of our forms of leukemia. But the hope is that over time, we will have potential ways to harness the patient's own immune system to help achieve the same goal. So that's a run through of where I think research is heading in AML, and hope I've given you a flavor of some of the some of the very exciting developments that are happening in this field. And I'll be very happy to take questions.
Excellent. Thank you very much, Dr. Brandwein, for sharing your expertise and insight today. So yes, it is time for our question and answer period. And at the time of registration, we had asked for your questions and had received an enormous amount of inquiries. So although we cannot get to answer all of these questions, we were able to choose some questions that we felt would help answer most of your inquiries. So let's start with the first question. Has there been any update on oral sorry, I couldn't pronounce that again. So azacitidine alternatives to the subcutaneous therapy?
Yes, great question. As many of you know, azacitidine or decitabine, which is the other hypomethylating agent, is only available or has only been available by injection, most of the time under the skin or subcutaneous or intravenous. And because it's an unstable drug, it needs to be given as soon as it's made up. So what that means is that patients have to come into the clinic repeatedly to get these treatments. In the case of azacitidine, that usually means 7 days out of every month. And that's a lot of traveling, and it's very challenging and difficult for people to do that, especially if they come from a distance. So it would be really nice if we had an oral azacitidine alternative or a hypomethylating agent alternative. And fortunately, there are a couple of new ones which have been developed. So just put up here on a supplemental slide. So the first one is called ASTX727. So this is actually decitabine compound, which has been made orally available. So what happens normally when you try to take decitabine or azacitidine by mouth is there are enzymes in the gastrointestinal tract that destroy it, so it doesn't get absorbed properly. So what they did with this is they combined decitabine with another drug that blocks the effects of this enzyme that normally would break it down. And they combined them together in a single pill. And so when they did this, and they were able to, they did some studies with this, and many of us in Canada were actually involved in these trials. They were able to show that you could achieve levels of decitabine in the bloodstream, which were very comparable to what you would get when you gave it by injection. So in fact, we were able to get proper absorption of this medication by using this combination, which is called ASTX727. And so this pill has just been approved by Health Canada very recently for treatment of patients with myelodysplastic syndromes. The only downside is, first of all, it hasn't been approved for AML, but we also haven't, or they haven't actually done the studies yet to show that the actual outcomes of treatment are comparable to when you give it by injection. We would hope that it would be because the levels in the blood are comparable, but that just hasn't been done. So we'll have to see what, how much it ends up being used. I think it certainly will be an advantage to people who live far away from cancer centers and allow them to receive this type of hypomethylating agent treatment. The second drug that's in development as well is called CC486, which is an oral azacitidine compound, and it's been studied in AML. It's not yet been used in the frontline setting, but it's just a matter of time. So these things are coming. We don't quite have them just yet, but we will very soon.
Thank you very much. Question number 2, what are my treatment options if my AML returns after initial treatment?
Right. Well, that really depends on the situation. It depends a bit on the goals of the treatment. So, for example, if you have received chemotherapy alone and gone into remission, and then the leukemia returns later, if you are a candidate for an allogeneic stem cell transplant, the general approach would be to give you a reinduction treatment to get you back into remission, and then from there send you for a transplant, which in this stage would be the only treatment that we know of that can cure the disease. If you had a FLT3 mutation, you could receive Gilitinib instead of reinduction chemotherapy, but regardless, the approach would be to achieve a second remission and then proceed the next step to a transplant. It's a little different situation if you have, say, an older patient who was not a candidate for a stem cell transplant. or is otherwise not a candidate for a transplant. It's also a different situation if someone has already had a transplant and is not eligible for another transplant. So in that type of situation, unfortunately, it would not be a curative situation. And there are treatments that are available, some of which I've shown you. But I think in that situation, I would strongly really recommend that people try to get enrolled in clinical trials as much as possible. Some of these new agents, as I've mentioned, are potentially very promising. Some of them may actually work and benefit patients, but even if they don't, the knowledge that we gain from doing these clinical trials would be of enormous benefit to patients in the future. So I think that's something that, you know, is an important option as well if we don't have really effective standard treatments.
Thank you for that. Question number 3. I have been cancer-free for 5 years now. What is the chance of AML returning?
So we actually looked at that question. As I'm sure you know, AML is a very fast-growing disease. And if it's going to return, it usually will do so in the first 2 to 3 years. Most of the time, if people are out beyond 3 years, the chance of returning is relatively low. But we actually went back about 10 years ago and we asked the very question of what is the risk of relapse, or how common is relapse beyond 5 years? And we went back over about 25-year period and looked at all of our patients at Princess Margaret Cancer Center that had relapsed. There was about 500 patients, and pulled out and asked how many of them relapsed beyond 5 years. And the answer was about 3%. So 3% of the relapses had occurred beyond 5 years. And that's just a fraction of all the patients that were treated, since not everybody relapsed, obviously. So what we can say pretty confidently is that if you're out 5 years and leukemia has not returned, the chance of it coming back is very low. It would be a rare event. You can never say the chance is 0, but it's certainly probably in the range of 2 to 3%.
Thank you. Question number 4. Are there any treatments that can be used as a maintenance treatment during remission of AML?
That's a great question. So up to very recently, there have really been no maintenance treatments that have been shown to be effective in AML. And that's why we've never offered it to patients. But there was a recent study that just came out actually using this second drug that I showed you here, CC486, this oral decitabine compound. And this was a clinical trial that was targeting mostly older patients with AML who had received standard induction and consolidation chemotherapy, but for whatever reason were not candidates for allogeneic stem cell transplants. And so those patients who had just received chemotherapy, they flipped a coin and they randomly assigned those patients to receive either a placebo or this CC486, which was a pill. And then they followed these patients out over a few years. And the results are shown here. And it just came out last year, in fact. The blue curve here shows the survival of the group that received the CC486 drug, and the gray curve, the ones that received the placebo. The top curve is the survival, the bottom curve is basically the remission duration. And what the study found was that the patients who received the CC486 drug on average stayed in remission about 5.5 months longer, and on average lived about 10 months longer. And obviously that was the first time that we had shown that a pill or a medication was actually a benefit as a maintenance treatment in AML. Unfortunately, the bad news is to follow these patients further out, those two curves came together, which means that it really wasn't a curative strategy. So it's really not a substitute for a stem cell transplant, which is a curative strategy. But for patients who, for whatever reason, are not eligible or decline a transplant, I think this would be a reasonable option. And it's something that hopefully will become available in Canada in the near future. We don't have it just yet.
Thank you. Question number 5. What can a patient with AML who has had a stem cell transplant do to help his or her body stay cancer-free?
Great question. I hear it all the time. I wish I had a great answer. It's really, unfortunately, we don't know of anything that people can do in terms of lifestyle, diet, vitamins, or anything else that really have any evidence, good evidence, will reduce the risk of their leukemia returning. I did show you the very new data with sorafenib for people who have a FLT3 mutation, but apart from that, we don't know of any treatments that will do that, that will lower the risk of recurrence. We have known for many years that patients who get some graft versus host disease seem to have a lower risk of relapse, probably because that ties in to some extent with the graft versus leukemia effect, but obviously that's something that the patient themselves don't have a lot of control over. So we'd like to see people have a little bit of graft versus host disease, but obviously not enough to make them sick. I think when we talk about staying cancer-free, though, I think we have to talk about more than just the leukemia. We do know that patients who've had stem cell transplants, especially if they've had total body radiation, there is a slightly higher risk of other cancers or second cancers developing later in life. It's not a very high risk. It's maybe 3% or so over 10 years, but it's higher than in the general population. So I think an important part of being cancer-free is to have regular checkups and general surveillance, so that if anything else develops somewhere else, that it will be picked up at an early stage and cured. So I think that's an important part of being cancer-free as well, obviously.
Thank you. Question number 6, what is the relationship between MDS, myelodysplastic syndrome, and AML, and its reoccurrence after remission?
Right, so maybe I can go back to one of my earlier slides that maybe can illustrate that. So this was the slide where I showed you the development of mutations over several stages and over years. So some patients will go through various stages where they may develop a myelodysplastic syndrome with low blood counts, and then later will transform to AML when they get more mutations developing. Sometimes they don't, they just develop AML out of the blue. But sometimes when we treat them for AML, we find that later down the road, they will relapse as a myelodysplastic syndrome. So what's going on there? What we think is probably happening in many of those cases is that our chemotherapy treatment has eradicated the leukemic clone, but has not gotten rid of this myelodysplastic pre-leukemic clone that survives the treatment. And then later date, that myelodysplastic syndrome, that myelodysplastic clone will grow back and the patient will show up as an MDS rather than as an AML. So it's something that we've learned over time, and it's probably what's happening in these cases. There is a close relationship between MDS and AML. Obviously, some of the same mutations occur in both. That maybe explains why sometimes you have this MDS arising at a later date in someone who's previously had AML. But obviously, there are other possible things happening behind the scenes as well.
Thank you. Question number 7. What are the effects of stem cell transplants and chemo on the body? And is there something I can do to help my body recuperate afterwards?
Another great question. Also a very complicated question. Obviously, these treatments do a lot of things to the body and have a lot of effects. Most of these side effects are temporary and people will recover from them over time. There certainly are things that you can do to help your body recuperate. As you know, one of the most prominent symptoms is fatigue and low energy. People become very deconditioned. They're not doing as much through this treatment. The first month, they may be in bed much of the time. Muscles get weak. People are anemic, which lowers their energy further. So it takes time, obviously, to recuperate. And I think getting involved in a graded exercise program can be very helpful in building some of the muscle strength and reversing some of the deconditioning. Many cancer centers have exercise programs that are tailored for cancer patients. They're not necessarily specific for leukemia, but I think leukemia's patients, if anything, have even more problems than others because the treatment is stronger. So I think I would encourage people to try to enroll in some of those types of supervised programs if they're available. I think time obviously is the best healer for many of these things, but there are other things, unfortunately, that we don't have good treatments for. Things like chemo brain and brain fog that a lot of people experience. Fortunately, it does get better over time in most cases, but sometimes it can persist for a long time, and we don't, fortunately, have a good understanding of it and how to deal with it. When you talk about stem cell transplants, that's a whole other thing, of course, because then you have potentially issues with graft versus host disease and its effects, which can linger for a long time. The steroid treatments that you get after the transplant can also make the muscles weaker, which makes exercise programs even more important and valuable. Sometimes the bones can thin out from the prednisone and other steroid drugs, so being on calcium, vitamin D replacements and supplements can be helpful in maintaining bone density. Potentially other medications to maintain bone density. So there's a lot of things people can do that will help them recover more, faster and to a greater degree. But time is the best healer for most of these things.
Excellent. Thank you very much, Dr. Brandwein. That marks the end of our question and answer period, but I do have a few more pieces of information to share. Would you mind scrolling towards the end? Yeah. Right after the question. That'd be great. Thank you. So we would like to thank you very much, Dr. Brandwein, for joining us today. That was a great webcast, lots of great information. And we would also like to thank our partner, AbbVie, for making this webcast possible today. So we know that 2020 has been an unprecedented year, and we know that cancer doesn't stop, that the need to fundraise has never been greater, and that people want to help. So although Light the Night has had tremendous success over the last 15 years, we need to adjust our strategy to the current reality. We are proud to announce that for the first time in history, we will be meeting as one community on October 24th, 2020. So from coast to coast, our community will come alive to share survivor stories, honor our heroes, and remember loved ones lost. So mark your calendars. The virtual Light the Night broadcast airs at 7 p.m. Eastern Time. Visit lightthenight.ca for more information or to register. So do not hesitate to contact the LLSC if you need more information or support. You can reach us by email at canadainfo@lls.org or toll free at 1-833-222-4884. Also make sure to check our website regularly to watch all past webcasts or for the dates of our upcoming webcasts. Just remind everyone that a short survey will be sent to all participants after the webcast. We would greatly appreciate you taking a moment to fill it in, as it will really help us to offer you the most valuable information in the near future. So thank you once again, Dr. Brandwein. Thank you all for joining us. Have a wonderful day and stay safe.